Carotid artery stenting has evolved significantly over the past 2 decades, transitioning from an alternative for high surgical risk patients to a mainstream revascularization strategy with a highly nuanced patient selection process. The decision between carotid artery stenting, carotid endarterectomy, and guideline directed medical therapy alone hinges on symptom status, anatomical factors, and patient comorbidities. Symptomatic patients. Carotid artery stenting is typically a class 2A recommendation for patients with recent TIA or ischemic stroke and 50 to 99% stenosis who have a high surgical risk for carotid endarterectomy, like radiation-induced stenosis, previous neck surgery, contralateral vocal cord paralysis, or severe cardiopulmonary comorbidities. In asymptomatic patients, the threshold for intervention is much higher, and guideline-directed medical therapy with high-intensity statins, targeted antiplatelet therapy, strict BP control remains the cornerstone. Carotid artery stenting or carotid endarterectomy may be considered in highly selected asymptomatic patients with more than 70% stenosis if the risk of peri-procedural stroke or death is strictly less than 3%. Anatomical unsuitability for carotid artery stenting include severe tortuosity of the aortic arch, type 3 arch, heavy concentric calcification, or highly friable thrombus-laden plaques strongly favor carotid endarterectomy over transfemoral carotid artery stenting. The debate between carotid artery stenting and carotid endarterectomy is anchored by several landmark randomized controlled trials with the CRUST, that is carotid revascularization endarterectomy versus stenting trial, data driving much of the current practice. CRUST 1 showed equivalent long-term outcomes for the primary composite endpoint of stroke, myocardial infarction, and death. However, peri-procedural differences were clear. Carotid artery stenting had a higher risk of minor stroke, while carotid endarterectomy had a higher risk of myocardial infarction. Sapphire trial demonstrated that carotid artery stenting was non-inferior and arguably superior in the short term to carotid endarterectomy in patients specifically identified as higher risk for open surgery.